Good afternoon. Thank you, Richard. Thank you for offering this possible opportunity. Well, we saw so far so many difficult cases in which you might expect to have complications, so you take into consideration before the surgery several ways of doing the surgery, plan A, B, and whatsoever. But nothing is more frustrating than to have a case in a standard case which you expect to go straight forward, and especially when you find yourself at the end of the surgery and maybe you are thinking of going home, or which is not the case. Anyway, let's go to my presentation. It is 68 years old hypermetropic male patient with cataract. He had few days before trifocal IOL implanted in the other eye with uncorrected visual acuity 20/20, and now he has the other eye. The surgery went perfectly, 4 minutes, no problem at all, and now I'm implanting it is a Panoptix IOL. I'm using the Royal injector, and I perform two 8 millimeters nasally because he has a bit of against the rule astigmatism, so I really got into trouble. And I will not tell you that it was a resident or a young doctor, it was me, and I could not believe my eyes. And further on, the blood was coming on, but my advice is, first of all, keep you calm, don't panic, try to breathe deeply and to assess the damage and try to limit the damage. And indeed, although it is very impressive, it happened so suddenly, so unexpectedly, and the blood kept coming. Despite of this, the situation was not that bad. So I had a good posterior capsule, I had a good CCC and a good bag, so I can go further with implanting the IOL. At least I shall have a good, well-centered trifocal IOL in the bag. And for that, I need to limit and not to avoid to enlarge the dialysis. For that, I implant 2 iris hooks, which will keep the iris more close to the limbus, let's say, to the root. Of course, I stabilize the anterior chamber in the bag and everything with OVD, with viscoelastic. And then I put these 2 hooks, very careful to be under the haptic, but on the iris, of course. Now I just stabilize the iris, and I continue very careful under plenty of OVD to implant the haptic, the trailing haptic, the second haptic. But again, plenty of OVD. You need to have a lot of space, and from this complication, I must tell you that this is the real time surgery, so I didn't edit anymore the video. So these are the, let's say, the normal time or the normal speed of the surgery. And I managed to implant very well the second haptic in the bag, so the situation is, look, the IOL looks well centered in the bag. Now I'm assessing more the dialysis. The blood kept coming on, but at a certain point it stopped. And I just wondered what should be next. Should I suture the iris? And my first intention was to suture it. That's why I started to make parotomy. But eventually I said, no, I will close the eye like this, put a suture on the 2.8 millimeter incision, limbal incision. And why is that? Because my patient was under topical anesthesia, and because I wanted to talk with him, to explain the next day what happened, to have a sort of consent, informed consent, and to do the surgery, the suture of the iris under block in more suitable condition, let's say. Yeah, so this is how the eye looked the first post-op day. The IOL is well centered, but the dialysis is there. And second post-op day with small pupil, undilated and dilated pupil. So of course I decided to suture the iris. And this is the surgery, the second surgery, done in accordance with the patient, of course. I used double-armed 10-0 Prolene, 1.5 5 millimeters from the limbus. I performed 25 sclerostomy. I decided to put 2 sutures according to the length of the dialysis, very well equally split it in 4 quadrants, and I used 2 sutures of double arm Prolene 10-0. It is quite difficult to work with this suture because the needle is very thin, very elastic, so it's sometimes it's difficult even to introduce it through the paracentesis. You can catch some stromal strands, but anyway, with being careful, you can do this. And now I have 2 knots of the Prolene sutures. I bury them in the sclera, and I can say that the pupil looks round, the iris looked well attached to its former root. I close the conjunctiva, and that is more or less the surgery. And then next day, I could say that I was quite happy with the result anyway. So this is how the eye looked post the re-intervention, without mydriatics and with mydriatics, air in the anterior chamber in order to have more stabilized the anterior chamber. And 1 month post re-operation, the visual acuity was very good, the IOP was very good, and I had a very well panoptics IOL centered in the back. So the patient was happy, and I also was very happy. Thank you for watching me.
Ozana, thank you. Why do you think this happened? Do you think there wasn't enough OVD in the eye and injected, or what do you think happened?
Well, we could say, but it was not at all OVD in the eye. 90% of the cases I perform hydroimplantation, and especially when I have a bit larger incision, which was the case here. As I told you, this patient had against the rule astigmatism of 0.75. That's why I performed the surgery on 90 degrees, because this is how I sit in my OR, on 2 millimeters, and then I perform 2.8 millimeters nasally or temporally, depending the eye, and I implant. But more than 90% of the eyes, as I just mentioned, I do hydroimplantation. Exception and totally contraindication, according to my thoughts, is floppy iris, for example, pseudoexfoliation syndrome, small pupils. So I do this only, the hydroimplantation only in more or less, let's say, standard cases. So this might be a cause, but this didn't happen so far. So I would exclude this cause. I think the cause was maybe a lack of attention from me. You need to go inside, even if you stay in wound assisted, you need to be parallel to the iris. And I think I was not parallel to the iris, so that was my mistake. And secondly, I had this royal injector with spring, which suddenly pushed too quickly and totally uncontrollable the IOL.
Yeah. Any further questions? So I have a question. From which arc length do you use 2 sutures? What is your limit where you say, okay, that's something I can fix with 1?
Yeah, well, it's a matter of eye, you know. You can, you can assess it on the table. For example, 2 hours iridodialysis, it's clear 1 suture is enough. But in this case, it was 4 hours. There were maybe more than 4 hours, and that's why I said 2 sutures apart with 1-2 millimeters between them, it would be enough. And it turned out to be enough. But I assessed it, I don't have a rule, I don't have a cutoff. I just decided on the table.
Yes. And air use, is it a routine thing?
Sorry?
The use of air.
No, it's not a routine, not a normal case in standard cases, but in this case I wanted to have deeper, let's say, anterior chamber after I washed out the OVD. Yes.
These particular cases where you fix in the superior region the iriditis?
Yeah. I prefer to have it there. It will go away in 2 days and it's not making any damage in 2 days.
Right on time. Thank you.
Thank you.